So this lecture we're going to be looking at heart failure and what does that mean for you as a nurse. Now remember, when we're looking at heart failure, we're going to be explaining what that is. We're going to look at the different things that happen within the heart, and then of course our complications and what we need to do for our patients. Again, as with the other lecture, let's look about our normal circulation. We've talked about unoxygenated blood coming into the right side to our pulmonary artery, goes down in through our tricuspid valve to our right ventricle, which then ejects the blood to the pulmonary artery, which goes to the lungs to get oxygenated, and comes back into the left atrium, which will then go through the mitral valve, which will then go through the aorta, which will then go to the body, and that's how we get our oxygenated blood and how we circulate our unoxygenated blood to become oxygenated, and the circulation pattern happens again. Remember, we learned way back in some sort of um, um, pathophysiology class that about Frank Starling law, which is basically your muscles are like a rubber band and they will stretch, and the ventricular muscle needs to be stretched by the blood volume that comes into there to produce an optimal recoil and a forceful ejection of the blood. So both understretching and overstretchings can result in less than optimal contractions, and this is what happens when we have our heart issues. So heart failure is basically that. It doesn't that the heart fails or quits beating. It's just that it's not pumping like it's supposed to. So when you have the heart, of course, not pumping enough blood to meet the body's oxygen demand for oxygen, we have that imbalance of oxygen supply and demand that we saw in angina in a previous lecture having to do with coronary artery disease. But heart failure will cause that same problem, except now it's going to be a more chronic condition. So it's a chronic progressive condition, not just an acute condition that can happen. So again, you can have heart issues because when you have a lot of atherosclerosis, maybe you've had an actual heart attack and that has caused remodeling of your heart. Maybe you have coronary artery disease where the atherosclerosis is in multiple places, hasn't totally clogged off, but it's still causing issues with the increased supply or the increased demand for oxygen that you cannot supply because you've got vessels that are partially clotted off because of the plaque that's on there. You might actually have structural disorders because maybe you have valvular heart disease, maybe you have hypertension, which is causing vasoconstriction, and maybe it has nothing to do with the heart, but it has to do with other parts of the body like renal dysfunction, and the kidneys aren't filtering, so it's causing backup of blood volume, and you're getting volume overload, and it's making the heart work harder. So there's multiple things that can cause heart failure, and we just need to deal with what happens when that heart failure starts to happen to the body. So we know that you have stroke volume. The stroke volume is just what happens of the amount of blood that gets ejected with each heartbeat, and that's going to be determined by preload. You've heard preload and afterload before. Preload is just the volume of blood in the ventricle right before it contracts, and afterload is the pressure or resistance against the heart has to work in order to eject the blood. And you know about systole and diastole. So here's pictorial representation, so the amount of blood in the ventricles at the end of the diastolic pressure when the heart is refilling back up. And then, of course, afterload is the resistance that causes so that the way the heart contracts. So as you know, the cardiac output is the amount of blood that comes out of the heart, hence cardiac output. You actually average about 4 to 6 liters of blood per minute that you actually run around your heart. Remember, most heartbeats are anywhere from 60 to 100 unless you're an athlete, and then your heart beats way more efficiently than the rest of us do. But again, your heart rate is controlled by your sympathetic nervous system and your peripheral nervous system. You learned all of that in a pathophysiology class. This is where it all comes together in the body. So remember, there's lots of factors that help with your heart rate. There's an ejection fraction, so the normal ejection fraction in a person is anywhere between 50 to 70%, and you calculate the ejection fraction by the amount of blood that gets pumped out of the ventricle over the total amount of blood in the ventricle. Remember, in your heart, you do not pump 100% of blood out of your heart. A little bit stays in. That's why what you take out of the heart is about 50 to 70%, because there's always going to be a little bit of blood that's left in the heart, which is totally fine. But you're looking at the total amount, the amount that gets pumped out, and then you are going to get a number, a calculated number in a percentage, and that is the percentage that we look at. So a normal ejection fraction is 50 to 70%. This will become very important to you, especially when you get into critical care and Med-Surg 3, when we start looking at people who have very poor ejection fractions and what we have to do with them in regards to that. So we have different types of heart failure. So the two major types of heart failure are, well, there's actually four types because there's left and right, and then here we have systolic and diastolic. Remember when we talked about the elderly, they said it's common for the elderly to have systolic heart failure, but if you have diastolic heart failure, that is something that needs to be followed up by a physician. So in systolic heart failure, we have a pumping problem. And remember, as your population gets older, the heart's been beating for quite a long time, and what happens is that the heart muscle can get weaker, and so as the heart muscle gets weaker, it's going to have difficulty contracting. So you're going to have a pumping issue because it's not going to be able to pump the blood that's in there. It's having a hard time pumping that blood out, so less blood gets ejected, which is going to thin out the muscle wall. So here you're going to see your clients have an ejection fraction of less than 40%, and that is what we call systolic heart failure because it is a pumping problem. And it happens as people get older. So the heart is weaker, less blood is pumped out, the weakened heart muscle can't contract, it kind of thins out. Diastolic heart failure is what we call a filling problem. And here in the diastolic heart failure, what happens is now you have stiff, non-compliant heart muscles. That's why it has a hard time filling. So a smaller blood volume gets into the heart because what happens is when the muscle becomes very stiff and non-compliant, it's actually going to get larger and thicker. And so it's not so much that you have a smaller blood volume, it's all that can fit in the muscle because the muscle has gotten thicker and enlarged. So it has what we call a cardiomyopathy because it gets a thicker wall. And remember, but the good thing is that even though you have a smaller blood volume in there, your ejection fraction will be normal. You will still eject that 50 to 70% out. It's just going to be less because you have less volume that's filling up the blood. So you can see here in the pictures on here the difference between the volume that's in the systolic versus the diastolic, which is why the diastolic does require some medical intervention, because as you can see there, yes, we're still getting the normal ejection fraction, but we're still having problems because we're still not getting enough blood out there because we have this bigger, thicker muscle on the left side that's really stiff and non-compliant. And so, yes, you can still eject that blood out of there, but it's still not going to be enough to get around to the body. So what happens in heart failure? As you can see on here, there are several things. So you have the decrease in the renal perfusion. So then, of course, the body, you're a compensatory mechanism. That's the way God made you. So you have the renin because it's going to help try to preserve that volume. So basically what ends up happening is then you're going to increase the preload and the afterload because the hormonal stuff has kicked in because it's saying, hey, don't have enough volume on here because the heart's not pumping efficiently. So I'm going to preserve the fluid that I can. I'm going to see if I can't get the heart to pump better on there. And what happens is it doesn't work any better. So the workload increases because the heart is working harder because it's got this fluid hanging on and it doesn't know what to do with that fluid. So it's just trying to get that fluid pumped out of there, and it's still not going to get enough fluid pumped out. And so therefore we increase the workload of the heart. And of course, reworking the heart remodels the heart a little bit because of the fact that it's going to get thinner in the muscle, or you might have hypertrophy on there if you have a diastolic problem going on. So again, it just becomes a terrible circle of things not functioning and failing until eventually the heart's going to literally kind of poop out. So the heart chambers are going to dilate to accommodate the excess fluid resulting from the increased vascular volume. And remember, it doesn't totally empty out. So you can see on here, it's going to cause over time, this chronic distension causes the ventricular wall to thin and degenerate. That's your systolic heart failure that we are talking about on there. And so this is the more common presentation, systolic heart failure. And so what happens is that you can see there the remodeling of the heart. The heart is bigger now. And so this is where you hear the terms like cardiomyopathy. And so even though you see this enlarged heart, you think, wow, it's really going to get all that blood out of there, but it doesn't. It degenerates, so it doesn't pump efficiently. So that's where you see your ejection fractions go below the 50 to 70%. After you've had a heart attack where you've had the acute infarction, we can see here we have this fibrous scarring, which again is going to affect how the muscle contracts. And you can see on here how the heart can thin and elongate, and you can see how you have this remodeling of the heart based on the fact that you've had an area of tissue that died, and the heart's trying to compensate for the area that's not working anymore. So it's trying to help and maintain that heart, and it just can't compensate for that. So you will learn about this when you get into critical care and also next quarter in Adult Health 3. So we do have classifications, obviously. So there's class 1, class 2, class 3, class 4. As you can see, class 1 and 2 are more of the mild symptoms, where you can see it doesn't really affect the physical activity. And you can see, especially in class 1, the activity doesn't really cause any symptoms. Class 2, there is some slight limitation, but you can tell that they can't do what they used to do before, because they do have some issues with their heart giving them some problem. Obviously 3 and 4 are the more moderate to severe heart failures, and you can see class 4, they can't even get out of bed without oxygen, and they're basically bedbound, and they have symptoms even at rest, versus before in class 1, 2, and 3, they had to do something to get their shortness of breath and to have their heart failure issues. So class 1 and 2 are mild. You have mild symptoms. In 1, it's basically asymptomatic, but their heart just isn't working like it's supposed to. And then once you get into class 3 and 4, there's really much more limitation on there. And there's marked limitations because of the symptomology that you see on there. And even doing, especially when you get into 3 where it's moderate on there, you can't even do your normal ADLs, and they're comfortable only at rest. So these are people who are usually on oxygen basically all the time, and you've seen the commercials where they make a comment about, let me give you advice, you can go only as far as your oxygen tubing will let you go, and that'll be your class 3 or class 4 patients. And some of your class 4 patients can't even get out of bed. They're mostly bedbound patients, because even to get out of bed and walking to the bathroom causes them significant shortness of breath. So let's go to the more common presentations that you see of heart failure, the ones that you probably will get tested on, as well as with the diastolic versus systolic, and that is left versus right-sided failure. So again, we need to think about what is happening in your heart. So when we're talking about left-sided heart failure, it means that the left side will fail. So basically what happens is you have to think about, where does the blood from the left side come from? So remember, the left side is fed by the pulmonary artery. So if you back up, it's going to back up into that pulmonary artery. That's why you see this dyspnea, the orthopnea, the fatigue, the extra pulses, the extra sounds, the pulmonary congestion, because of the fact the left side is failing. So therefore the fluid's going to back up into whatever feeds the left side, which is the pulmonary artery. And remember, when you have that congestion, it's going to decrease your oxygenation, which can cause altered mental status. Remember too that the left side feeds the whole body. So if the aorta is not pumping significantly, that means you're going to decrease perfusion to the organs. And so therefore you could have decreased urine output, and that could lead to oliguria. So left-sided failure, the backup is to the lungs. Hence the pulmonary congestion, everything lung-related, as well as oxygenation to the whole body, because that's what the left side does, sends oxygenated blood to the body. Right-sided failure. Right-sided failure, where does it feed from? The body. So the right-sided failure, when it fails, you will see the backup of fluid in the body. So what you're going to see is you're going to see fluid hanging around in the body. So you're going to see jugular vein distension. You're going to see edema. You're going to see organs getting distended. So abdominal distension, ascites, liver enlargement. You're going to see weight gain because the fluid is backing up into the body. That's why heart failure patients are always weighed, regardless of whether they're right or left-sided failure, it doesn't matter. So right side backs up into the body. So you're going to be looking at edema. And a lot of times you're going to see right and left-sided failure together, because the heart is so damaged that it really can't pump on either side. So you might even see right and left presented at the same time, but you need to separate which one is left, which one is right. So right side backs up in the body. Remember, if you're getting a lot of fluid there, you might get polyuria, because the fact you've got all that fluid hanging out, so it's just going to get wasted in the kidneys. But majority of the time the fluid collects in places, and so one of the places it collects, of course, is in the belly, so you're going to see ascites. So our triad of classic heart failure symptoms are the shortness of breath, which is the left-sided failure, edema, which is the right-sided failure. And regardless of which side of failure you have, it really puts a lot of stress on the body, so the body is always fatigued. So fatigue is a very typical presentation of your heart failure patients. So we know what our heart sounds are. You have the lub-dub, So lub dub, of course, is beginning of systole. Dub, of course, is diastole. So this should be review for you about where your heart and when you listen to your heart. So aortic, pulmonic, the second intercostal spaces, and then of course Erb's point on there, which is the middle of the chest, and then of course tricuspid and mitral valve. So all people enjoy Time magazine. And you want to be listening, and you go down with the diaphragm, you go back up with the bell because you need to hear for the murmurs. So those are the reasons why we make you listen to those sounds on there, because we need to hear if you hear the sloshiness of the heart failure, and you will hear the that it is having issues, and you could hear the workload of the heart because of the fact the heart will beat faster because of the fact it's trying to compensate for all of that fluid buildup that's there. We used to have to measure drug-eluting venous pressure. You still do. You'll get more detail in Nursing 303, and you will actually have to do the skill in critical care. They now have machines that help you do this, but before we used to do, just like you see in the left-handed picture, we actually used to use 2 rulers, and what you did is you measured how high it was above the skin, this jugular vein thing. Back in the days of when I had to do it in school, that's how we had to measure it back then, but now we have these wonderful little machines in critical care that will do that for you, and you won't have to do that as a skill, but you will learn it in critical care. Obviously, if you have somebody who has JVD or jugular vein distension, you know that they have a right-sided failure going on, and it is causing backup of fluid and extra workload on the heart. There is an actual diagnostic indicator that we look at, and that is the B-type natriuretic peptide. The natriuretic peptide is a hormone released by the ventricle in response to volume. So obviously, as the number goes higher, the more significant your heart failure. Again, I will not have you memorize numbers. However, if I do give you a reference range, you need to understand what that means. All it means is that the higher the number, the more significant the heart failure. So obviously, if you ever see a BNP and you see it like at 1,000, you know that the patient has significant heart failure. Of course, we're also going to look at electrolytes, because remember, if fluid is collecting on there, it's going to skew all of your electrolytes, especially if you're putting stress on the kidneys. You're going to want to do those electrolytes that have the BUN and creatinine. So all those Fab5 that you learned in 301 becomes very important in this class as well. So we'll do UAs, we'll do BMPs, or the basal metabolic panel, as well as the BNP, the beta natriuretic peptide. And again, you need to understand that. Remember, it's causing workload on the heart, so we need to make sure you're not in the process of having an MI. So we're going to do our cardiac enzymes. So you're going to see the high sensitivity TROP-T, the creatinine kinase, or the CK, and the CKMB, the myoglobin. We're going to do an EKG. We need to see how your heart is affecting the electrical impulses in your heart. These people will automatically be on telemetry as well. So there's all sorts of things that are happening to this patient. The echo just tells us what is going on with the heart. It'll show us movement of the blood flow through the heart, so we can see if there's any abnormalities in the heart valves. We can see what the heart size is. It actually will tell us what the ejection fraction is. So if you hear that the patient has to go for an echo, that's what we're doing, is we're looking at this non-invasive, which is what makes it nice. We don't have to poke anybody. It's a non-invasive procedure that sends these ultrasound waves into the chest, and we can see the moving pictures of the heart, and you will actually see that on the echo, and we can see how much of the blood really is getting pumped around and in and out of this heart. Now, we need to think about, okay, what are we going to do for this person? We know they have a sloppy heart. What can we do to help make it better? So when you think about what your meds do, think about the mechanism of action of the drug and how that's going to help your heart failure patient. Our drugs of choice now have changed a little bit. So we now look at our beta blockers as one of our drugs of choices, as well as your ACE inhibitors. Now, beta blockers, you know, have that wonderful LOL, and then your ACE inhibitors have that PEARL, that's the ending. Now, the reason we use the beta blockers first is it helps the heart beat more efficiently, as you know, for that you learned way back in your Nursing 301 lecture. So in this class, you will get the generic name, you will get the trade name, and I will actually give you the classifications, because at this point in time in your life, it's really important that you look at what the drug does. As you become more advanced, they'll start taking away the classification, but in this class, I will give you the trade name, the generic, and I will give you the class of the drug. So your ACE inhibitors, of course, work through the kidneys, and so they help lessen the volume that goes into the heart, and so therefore that will help with helping the heart beat more efficiently, because you're going to decrease the workload, because you're going to run it base through the kidneys and have the kidneys kind of help lessen that volume that goes back up into the heart. The ARNI is an angiotensin receptor inhibitor, neprilysin inhibitor. You've probably seen the commercials for Entresto. Entresto is a combination drug. Notice that one of the drugs of Entresto is valsartan, and sartan is an angiotensin receptor blocker, which also works through the kidneys. It's very similar to an ACE inhibitor, but it works differently because it actually works on the receptors. So that's why it's in a receptor blocker, and it works with a different drug on here. And Entresto is utilized for helping to prevent the degradation of that natriuretic peptide. So it's actually going to help with that BNP by helping support that natriuretic peptide and prevent it from getting taken out, which is why the BNP level goes high, because the natriuretic peptide is being destroyed, so the level goes up. So this helps with that prevention of that breaking down of that natriuretic peptide. That's why it's really been approved and used for chronic renal failure within the last few years. So that's why you're seeing all these commercials on Entresto for your chronic heart failure patients, because it's helping to reduce readmission to the hospital, because it's helping with the symptomology and helping with the and preserving our ejection fraction. Now, remember, angiotensin receptor blockers can cause angioedema, can cause some respiratory issues, so that's why you'll see angioedema here. Again, it also is a blood pressure drug, so of course it would cause issues with your blood pressure as well. However, the good thing about this is because it's with another drug, it causes less issues with our hyperkalemia. Remember, when you learned about your blood pressure drugs, you learned that ACE inhibitors and ARBs can cause the potassium to retain, and so people had problems with hyperkalemia. That was a side effect of those particular drugs. With this particular drug, this ARNI with Entresto, we see less issues with the hyperkalemia, but remember, it's still a blood pressure drug, so you can still see the blood pressure drop. So our drugs of choice will be the beta blockers. Remember, if you give a beta blocker, we always have to watch the heart rate. You hold the drug if the heart rate is less than 60, because beta blockers do cause bradycardia. If you have an ACE inhibitor, we just talked about the hyperkalemia. ACE inhibitors also tend to cause that cough because of the bradykinin breakdown. And then the ARNIs, the angioedema, or the facial swelling. That's really what angioedema is. So those are the drugs of choice. We usually pick one, or sometimes they will do two. So they'll do the ACE inhibitor and the beta blocker together, or they will use the ARNI as they need to. So again, you're really always following up after. Now, if the lungs are wet or if they really sound congested, that's when we'll add the diuretic. Because remember, when you add Lasix, our side effect of Lasix is you will drop the potassium, and if the potassium drops, we have other issues. So we need to remember that if the lungs are wet, that's when we add the diuretic. So a lot of times we'll work with the beta blockers and the ACE inhibitors, and then if we need to, we'll add the Lasix as needed. And of course, when Lasix happens, you're going to see fluid volume. So if the Lasix is kicked in, we hope to see this urine output go up. There's other drugs that we can utilize as well. So again, you need to understand, why are we giving these drugs? Spironolactone is a potassium-sparing diuretic. So while Lasix gets rid of the potassium, an aldosterone antagonist, which aldosterone, of course, the end product of the RAS system, helps to preserve potassium, so you can get problems with potassium retaining versus losing with this particular diuretic. So spironolactone is a mild diuretic. It helps with that. Remember, we have dilation issues, so we want to improve circulation by vasodilation, so we'll add nitrates. So you've seen nitroglycerin before because we gave it sublingually for people with chest pain, but you can give nitroglycerin as an oral form in isosorbide dinitrate, or Iserdil. And in this case, it's not going to work within 5 minutes. It's going to work over time. This is a prophylactic medication when you use a nitrate. The other way that you can use nitroglycerin is as an IV drip, and you will see this in your ICU setting. And they'll use these for your MI patients to help cause vasodilation. So the nice thing about nitroglycerin is it can be given as a sublingual, it can be given as an oral, and it can be given as an IV. But its main function is to cause vasodilation and improve that circulation, sending oxygenated blood throughout the body. The other drug that you might see that used to be the drug of choice for anybody with heart failure was DIG. But DIGE has a very narrow therapeutic window. And so the problem with DIGE is that people could get DIGE toxic very easily, especially if they weren't watching their drugs and they weren't watching their diet and they were having potassium issues. So while we don't see DIGE as first drug choice anymore, it is still an option. Because remember, what DIGE does is it helps the heart beat more efficiently. So what beta blockers do, DIGE does as well. It improves contractility, so it increases that stroke volume, and again, it just helps that heart beat more efficiently. Because remember, our heart is a little sloppy, it's not pumping efficiently, so DIGE helped the heart beat more efficiently. Unfortunately, because of the fact it could cause toxicity and get to toxic levels quicker, it's not, it kind of fell out of favor when we got better drugs. So you will still see DIGE, in all honesty, in a lot of your older patients, because I still see patients who are on DIGE, but you won't see it as commonly anymore, just because of the fact we have better drug therapy now to help do the same thing. And then, of course, when we talked about having wet lung sounds, we always use our high loop diuretics, because we need to get rid of that extra fluid, because all that fluid does is add workload to the heart. So we want to decrease that excess fluid. You want to get that edema down. So they'll be on Lasix, and we're talking high dose Lasix, like 40 milligrams, 60 milligrams, 80 milligrams of Lasix, to help get rid of that excess fluid and decrease that workload on the heart. So for your aldosterone antagonists, our side effect that we watch out for, of course, is the hyperkalemia. The vasodilators, we need to be careful because it causes vasodilation, which will cause hypotension, especially orthostatic hypotension. So for especially your older adults, who are your ones who usually have chronic heart failure, these people are now at a higher risk for fall precautions, because as you know, orthostatic hypotension, they sit up on the side of the bed, they get dizzy, they can fall down. The DIGE toxicity, remember the positive inotropes, the DIGE, while it does help the heart beat better, like I said, it has a narrow therapeutic window, so it's easier to get to a toxic level if you're not careful. And the other thing it can cause is it can cause bradycardia. So that's why DIGE is another one of those that you have to do an apical heart rate, and it will ask you what the apical heart rate is, and it needs to be over 60. So just like your beta blockers, DIGE also, the heart rate needs to be over 60 before you give the drug. The other thing with DIGE is that it has a decimal. So you shouldn't be giving 1 milligram of DIGE. It should be 0.125, 0.25, 0.5. There should always be a decimal when you give DIGE. Diuretics, of course, we talk about dehydration and hypokalemia because it is going to pull out that potassium. So your loop diuretic or your thiazide diuretics, you will cause hypovolemia as well as hypokalemia. So you do need to be careful when you give those diuretics. Now, digoxin, like I said, it used to be the drug of choice that we used to treat for heart failure. We still do give it for anybody who is in AFib, and you will learn about AFib when you get into critical care. But just, you know, afibrillation is when the atria quiver. Obviously, ventricular fibrillation, that's the one you learn in your ACLS class, or you will learn, and that's when the ventricles quiver. That one is more life-threatening. But anyway, what DIGE does is it increases the force of the myocardial contraction. That's why we call it a positive inotrope, because it helps support contraction. So when you do that, what it does is for your heart failure patient, it increases cardiac output, which will then increase perfusion to the body, not just to the kidneys, but to the whole body. So it slows the heart rate down and helps the heart beat more efficiently. That's really what digoxin does. The bad thing, of course, about digoxin is that there is a narrow therapeutic window. You can see here 0.8 to 2 nanograms per deciliter when you're looking at your DIGE. So if you have anybody on DIGE, the doctor needs to order a DIGE level because you need to see where they are. If the patient complains of a headache, if they complain of anorexia, which is probably the most common side effect of somebody who is DIGE toxic, is the anorexia, the drowsiness, and then vision changes. They'll see auras around the lights. They'll see green, yellow halos around the lights. That's the vision changes that they talk about. But the anorexia, the loss of appetite, is a very common side effect of DIGE toxicity. That's why it's so important that you continually assess your patients anytime you give any kind of medication. So DIGE toxicity, visual disturbances, anorexia, abdominal pain, sometimes confusion. With the geriatrics, you need to be really, really careful for bradycardia. And remember, they're a little bit more sensitive to the electrolyte imbalances, so they have a higher risk actually for DIGE toxicity because they're the ones who will have the potassium issues. And if you are hypokalemic, meaning your potassium is less than 3.5, these are the people who are at the higher risk for getting DIGE toxicity. We have to be careful if your patient is pregnant, obviously more for your pediatric and your geriatric patients. So pregnancy and lactation, you don't really see very many pregnant geriatric patients. But you still need to watch out for the nausea, vomiting, the abdominal pain, anorexia. So DIGE toxicity, again, we don't use as much DIGE, but if you have somebody on it, please make sure they've drawn some sort of a level so that you can assess. Now remember, we want to make sure that the left ventricle is really doing what it's supposed to do, because remember, the left ventricle is the one that pumps to the heart. We do have a cardiac cath lab in the medical center, so here's a picture of our people here in the cardiac catheterization lab. You can see that they've got several monitors so they can see what they're doing, as well as lots of cameras to help us evaluate what's going on with the heart. Remember, if you're going to do a cardiac catheterization, it's going in a femoral. So remember, we've talked about checking for allergies because we use a dye. We need to have baseline labs, make sure that our kidneys can clear the dye. You need to make sure that you have good pulses, and you will mark them so that post-procedure we can just check, because we already know where to look for it. We don't have to do the seek and search mission afterwards. And remember, if there's any changes in the pedal pulse, please call the physician right away, because what's happening is you are cutting off circulation down there. You do not want to cause a complete loss of circulation to the leg, because you'll end up having to do amputation. It's just going to get really bad. Remember, call for any abnormal labs post-procedure, especially if it's significantly hypertension. Blood pressure is going to be a real big problem. They're NPO prior to the procedure, and in a way it kind of helps if they're NPO, because it helps the dye show up a little bit better, because they're a little bit dehydrated because they've been NPO, even though they've got IV fluids running. Again, if you have any questions, the doctor talks to them about the procedure, but the patient may have concerns as well, so you need to make sure you do good explanation and documentation of that explanation. As you can see here, and in another place, in another lecture, I do show you how the PCI works on here, but you can see they go in the femoral artery on there, they thread it up, and then they will open it up, and they'll show you where the blockage is. And you saw the big TVs that they have in the operating room on there, because they show you where those blockages are and how we can open it up and cause perfusion to be reestablished with your patients. So post cardiac cath, they always look at the site, make sure there's no bleeding. It's going to be very close monitoring of vital signs. By the time they get back to you on your med-surg unit, the vital signs should be every hour for the next 4 hours. Again, you're going to take a look at your pedal pulses, make sure the pedal pulses are there. You're going to check the site, make sure that there's no bruising. If there is bruising, put pressure on it. If there's oozing, put pressure on it. Patient has to be on bed rest for at least 12 hours. So make sure that they've got a urinal at the bedside if it's a male. If it's a female, they have access to a bedpan, because you really don't want them getting up and walking, because it will cause the site to bleed. If it does bleed, put pressure on it, call the doctor, let them know. If you lose the pedal pulse, call the doctor, let them know that is an emergent situation, and just continue to monitor every hour for about 4 hours, and then it goes back to Q2 after that. And again, you're just watching the site, make sure that there's no bleeding. Just keep holding pressure until the doctor comes up to reevaluate. Sometimes they have to stitch it. That doesn't happen very commonly, because pressure right away usually will stop that bleeding from happening. Now, when you have somebody who is going home, you're going to be teaching them about why they have to take the medication now, why they have to do this, and why is it going to help their heart failure. And you need to talk about diet as well. You need to talk about how they should take these medications, what happens if they miss a dose, how to use the pill box if they can't remember and this is the first time they're taking medication, how other medications can affect other medications. So it's really, really important that you're always educating. And remember, education doesn't happen in one day. Education should be continuous. Every time you go in there to give them medication, you should be educating them. So by the time they go home, they already understand what the medications they're taking, because they're already taking them in the hospital. For your heart failure patients, they need to weigh themselves every day. So they need to weigh at the same time, they need to weigh on the same scale, and they need to weigh on the same amount of clothing. So I always tell them You're already in your pajamas. The first thing you do is you walk into the bathroom, you go pee, and then you stand on your scale. If there is any kind of weight gain, 2 pounds in one day or 4 pounds in one week, or you see increased swelling, call the doctor, call your healthcare provider right away. They'll ask you to record your weight. And so you should have a weight log, and they will give that to you on discharge. So there should be a weight log that you can give to the patient that is under the heart failure educational process on there when you look at your education. If not, you can download it off the internet. You just have to look under heart failure or daily weight, and it will give you a log. They need to record that weight on there so they can see that they are not gaining any weight. The diet will also change. Your cardiac diet usually is a low sodium, low fat diet. The low sodium just means basically no added salt and no processed or canned foods. So they shouldn't be driving through McDonald's or driving through someplace else. So no salt shaker on the table. Cook with lemon. Be careful on your condiments because ketchup and some of your other sauces are high in sodium. They're going to need to learn how to eat the lean protein, skinless, or skinless chicken, some of your fish, no skin on the fish. So they're just going to have to learn how to do the diet changes on there. A lot more fresh vegetables, a lot more fresh fruits, and again, less than 1.5 grams of sodium, which, we live between 6 to 8 grams of sodium basically with every meal. So this is a huge change on there, and you might need the dietitian to come and help them look at alternate foods that they can utilize while they learn how to live with heart failure. We do want them to exercise at least 30 minutes a day. Walking is good. Start slow, work up to tolerance. This is the time for you to do something for you. So they can exercise with their spouse, exercise with a friend, but they need to exercise. That is the bottom line. If they should have chest pain when they start walking, they need to just stop and see if the pain alleviates. Again, if the pain doesn't alleviate, call 911, get them to a hospital. If they've got nitroglycerin, pop a nitroglycerin in their mouth and treat it like an MI. If the chest pain alleviates, then you can have them walk back into their house, and then what you do is you just start again the next day, and they can follow up with their healthcare provider if they've had the chest pain episode and let the healthcare provider know, because maybe they need to do alternate. Instead of walking, maybe they need to do swimming, maybe they need to do a stationary bike. But we do want them to have some sort of activity where you have active perfusion going on in the body. Again, if you have any shortness of breath, or if you start to have chest pain that starts to worsen, or if you are helping your family member and they seem like they're more confused, call 911, go to an ED, call the primary provider, let them know they're having problems. If they're having problems sleeping, call the primary provider. If you see that they can't walk like they used to, call your primary provider. Anything just that's different than what their baseline is, call the primary provider, because we need to reevaluate what's going on. Heart failure patients are known for frequent readmissions into the hospital, and so if we can prevent that from happening because you've intervened really early, that would be key for the patient continuing in good health. Heart failure complications. Most common complication is the left-sided failure where the fluid backs up into the lungs, and that's pulmonary edema. People can actually suffocate, quote unquote, because of the fact that fluid fills up so much in the lungs. So it is considered an emergency. So if you have somebody significant pulmonary edema, you will know they'll have hard time breathing, their O2 sat goes down, their lungs are really with the rails because there's a lot of congestion on there. Please get them into the hospital as soon as you can. Already in hospital and you notice your patient is starting to have a sudden onset of breathlessness, they feel like they're suffocating, they're tachycardic, they're anxious, they feel like they're going to die. Maybe they have a productive cough with kind of a pink frothy sputum. Remember, this is plasma proteins, and RBCs have now gone into the alveoli and the airway, so you might see that pink frothy sputum on there. Again, you should be on the call to the doctor on here. If you feel like you're not getting much success on there, you can call a rapid, get some more help up there to help with getting the airway open. It might require intubation, which means the patient has to go down to a higher level of care, to an ICU. But if you can catch the pulmonary edema early, we can take care of it early on. So this is why it's so important you do that good baseline assessment and really listen to the lungs if you know you have a heart failure patient. Of course, if you have pulmonary edema, you'll notice on here there's several mnemonics on treating pulmonary edema. The main thing is to make sure they're on oxygen, make sure you do ABGs, do a chest x-ray, see how much we are looking at as far as the congestion is of the lungs. We can give our drugs like you do for your MI, your morphine, your nitroglycerin, of course put them on oxygen. Encourage the turn coughing and deep breathing to move those secretions around so you can cough them up. Remember, our goal of these interventions is to promote diuresing of this fluid and maintain that cardiac output so that the heart remains perfusing. Cardiogenic shock will actually send them into ICU. You never want them to get to this point in time because cardiogenic shock means that we don't have enough blood to perfuse our organs in the body. So you're going to see pale skin, a weak, thready pulse. By this point in time, you're probably calling a rapid or maybe even a code blue, even though they've got a pulse and respirations. Because of the fact they need a higher level of care. You need to get them intubated. We need to make the heart quit working so hard. They're going to require further follow-up and some really significant follow-up that won't be available to you on your general med-surg floor. But you'll see profuse sweating, agitation, confusion, things like that. This is where you're going to see the ventricular assistive device and the LVAD, or the left ventricular assistive device. And this is outside of the body, and this is an external way that it helps treat the sloppiness of the heart and helps the heart pump a little bit better. This particular patient in cardiogenic shock will be transferred to ICU, so you will see cardiogenic shock again in critical care. But you want to be able to recognize when they're going into this so that you can get the rapid response going and get them transferred to a higher level of care. So you need to be able to recognize so we can get them to where they need to go so we can correct what's going on with this heart. Thank you for listening. We'll see you in class. Thank you.